part of what I'd like to do here, and I very much appreciate the opportunity to speak with you. What I'd like to do is I'd like to give you sort of a short presentation that I've prepared here called What is Schizophrenia? Because I understand that you all just, one of the reasons we're gathering today is that you all just finished the book Hidden Valley Road, Inside the Mind of an American Family, about the Galvin family and its remarkable family history of schizophrenia. And Rita, who is my mother-in-law, knowing that not only am I a psychiatrist, but that I have a specialty in treating people with schizophrenia, thought that it might be interesting for you all for me to give you a little bit of a presentation as an overview about this condition that we call schizophrenia, and then answer your questions with the understanding that I actually, full disclosure, I did not read the book. I'm familiar with the family. I'm familiar with the case and sort of some of its implications, but I haven't read the book. So you all are much more familiar with this specific story of this family than I am. But I thought with my background, as Rita just shared with you, in helping to run the schizophrenia unit, in fact, the treatment-resistant schizophrenia unit at this large not-for-profit hospital that we have here in Baltimore, really 150-year-old hospital that actually, whose history is tied in with the modern American history of schizophrenia. We were actually one of the important centers in which many of the ideas about schizophrenia were developed at Shepherd Pratt Hospital here in Baltimore, including one of our famous directors who was named Harry Stack Sullivan, who was very celebrated in the world of schizophrenia as having developed some of the techniques for using psychotherapy with schizophrenia. So we have a unit that has often, that has been around for at least 40 years, that has accepted people with schizophrenia from other hospitals where they were not getting better. So that's why we call it the treatment-resistant schizophrenia unit. So I was the co-director of that for many years. And now, although I do mostly outpatient psychiatry, I have a specialty in schizophrenia. So I wanted to share some thoughts with you about this and sort of what our current state-of-the-art understanding is of this condition. And I just need to adjust my screen one more second here to make it more easy for me. All right. So schizophrenia, really one of the reasons that I'm interested in it is that of all the conditions that we psychiatrists treat, this is probably the most serious, the most disabling, the most severe of all of the so-called major mental illnesses that we treat. In the major mental illnesses, we include things like bipolar disorder, otherwise known as manic depression, severe anxiety disorders, PTSD, but almost in many ways the most severe, the crown prince of severe mental illness is schizophrenia. And the New England Journal back in 1994 called it the worst disease affecting mankind. The Treatment Advocacy Center down in DC, which is one of the world centers for dealing with issues of severe mental illness, calls schizophrenia one of the most disabling diseases affecting humankind. So this is something that has really been the forefront of primarily what especially inpatient psychiatry has dealt with over the years, because these are the kinds of patients who are more likely than not to end up in the hospital. But just some important history with regard to that. Turns out that actually through the majority of human history, that most of the people who were in so-called insane asylums, as they used to be called, for the vast stretch of history, actually had a form of syphilis, the most common cause of severe insanity, of the kind of psychotic symptoms that we're going to be talking about today, by and large used to be a late stage of syphilis called tertiary syphilis. I would say 95% of people in psychiatric asylums throughout most of recorded history have not had schizophrenia, they've had syphilis. Why? Because syphilis was actually quite a widespread illness. It was highly contagious. As you all know, that it's transmitted primarily through sexual contact. And many a civilization was actually rather hobbled by an epidemic of tertiary syphilis, or of syphilis in general, but the late stage being this so-called tertiary stage was accompanied by severe hallucinations, delusions, profoundly disturbed behaviors, the kind of thing that is often depicted in some of these old paintings and old renderings of what life in asylums used to be like. So in fact, now most doctors my generation and younger have actually never seen a case of tertiary syphilis. Why? Because we developed antibiotics to treat it. So in many ways, interestingly, the development of antibiotics was probably the single most significant development in the history of psychiatry in terms of an effective treatment for mental illness, because the majority of mental illness used to be syphilis. As we began to be able to treat syphilis, and as we began to lower the vast proportion in mental institutions of syphilis, we began to see that lost in that noise was a different population that had a different kind of course. And that population was really first identified by this German psychiatrist, Emil Kraepelin, who identified an illness that began in early adulthood that represented actually a rather small fraction, at least back in the late 19th century, was still a small fraction of people in mental institutions. And he called this dementia precox, which literally means early dementia. Why? Because it really resembled the late life dementia in the sense that people had a deteriorating course, except that this was beginning in young adulthood. And he called this dementia precox. And it really was to another psychiatrist in Switzerland named Eugen Bleuler, who in 1908 coined a term for the first time, which he called schizophrenia. And he said there are actually a collection of conditions that he said was sort of a family he called the schizophrenias. And he was able to kind of tease this population out, which became increasingly the majority of populations of inpatient or asylum psychiatry with the advent of antibiotic. Now, Bleuler was able to see that this group of people had some characteristics that really created a sense of a syndrome, which we'll talk about in a minute. But he identified things that are still to this day referred to as the 4 A's: affect, associations, ambivalence, and autism. And affect meant that these people had an impairment in their ability to express themselves emotionally. Their emotions tended to be very flat or very excited. So there were disruptions in emotional expression. Associations referred to the fact that when these folks identified in this group would try to communicate, their communications were often very garbled. They didn't make sense. The structure of their sentences and paragraphs were very difficult to follow. The sense of their language seemed to be jumping all around. Another thing they identified, another A, was ambivalence. Ambivalence was a fascinating thing in which people were able to hold simultaneously 2 ideas that seemed to be mutually contradictory. So for example, they would hold the idea, I am perfectly safe and people are trying to harm me. Those things seem like they would be mutually exclusive. but people with this syndrome would be able to say both of those things simultaneously. So there was an illogical sense of incoherence to their use of logic. And then autism. And autism is not what when he used the term, it's not the modern use of the term. What he meant by the term autism was that was referring to a break in reality. People who lived, who had ideas that were not congruent with reality. Specifically, they suffered from delusions, which we'll talk about, and hallucinations. So these four features he felt captured a family of diseases where people had maybe some different courses. Some people had more of one, some of the other. The word schizophrenia, which literally comes from the Greek, which means fragmented mind, is something that he felt applied to this. It's unfortunate because the term split mind or fragmented mind has led this illness to be confused over the last 100 years with multiple personality disorders. It's a very common misunderstanding. In fact, I've even seen this level of misunderstanding in highly educated people. So if you felt that schizophrenia before perhaps you read this book referred to multiple personality disorder, you're not alone. You keep company even with some university professors I've met who confuse these two terms. Multiple personality disorder was not something that really emerged in psychiatry for at least 50 more years after Bloiler first articulated this concept of schizophrenia. So let's talk a little bit about the concept of a syndrome. And I've illustrated this with a syndrome with which many of you might be more familiar than schizophrenia. A syndrome is an assortment of symptoms that travel together, kind of like a constellation of stars that hang together in a way that you can see a pattern. So I've illustrated this with the notion of a heart attack. So a heart attack can include a variety of symptoms. It can include chest pain, pain going down your arm, pain in your jaw, shortness of breath, sweating, nausea and vomiting, and anxiety. Now, when you go into an emergency room and you present with these things, these symptoms, a physician will identify those symptoms as a recognizable pattern. Maybe you don't have them all. Maybe you don't have the jaw pain. Maybe you don't have the shortness of breath. But you have enough of the symptoms that are traveling together that a physician can say, I think you may be having a heart attack. So the question is, are you having a heart attack? And is it what we call in medicine an actual death of the cardiac tissue, which we call a myocardial infarction? So you start with the clinical domain of these symptoms, in which you ask the patient, gives a history, you do an examination, but you still aren't sure, is it a heart attack? Well, we have, in cardiology at least, we have another domain that we can go to. We can go to the domain of laboratory tests, of biology. And we can take this patient with this this constellation of symptoms, and we can look at their EKG, and we can see looking for characteristic changes in the electrocardiogram. We can do an echocardiogram where we can look at the motion of the heart. We can do blood tests where we can test the enzymes that are in the blood that are released by the damaged heart muscle. We can do a catheterization. We can even ultimately do a biopsy and get a piece of tissue of the heart in the more extreme cases to see if indeed there is dead tissue in the heart. And utilizing this other set of information, the laboratory information, we can say, yes, this is a heart attack, or no, it's not. Maybe these symptoms turn out to be something else. Maybe it's reflux. Maybe it's, hold on, somebody is asking to be admitted. I'm not trying to see how to do that. Excuse me a second, because I'm the host here, so I'm also admitting. Okay, somebody's coming late. So if some of these laboratory tests are positive, we can say definitively you'd had a myocardial infarction. If they're not, we can say it looked like a myocardial infarction, but it's not. So schizophrenia, and in fact, as a matter of fact, almost all of the major psychiatric disorders that we have, we understand them as syndromes. They're a collection of symptoms that we can identify both on the basis of taking a history about the story whereby those symptoms came on, and by doing an examination in the present by looking for those symptoms. But in psychiatry, we do not yet have another domain of laboratory tests where we can say, aha, yes, this is schizophrenia. Yes, this is bipolar disorder. Yes, this is post-traumatic stress disorder. Yes, this is attention deficit disorder. We do not have that. So psychiatry really, the state of the art in our field is primarily on the left side of the screen, the domain of clinical symptoms. So let's look at the syndrome, collection of symptoms of schizophrenia. And when we think about the syndrome, we really divide it into two different areas, so-called positive symptoms and negative symptoms. Positive symptoms, we use these terms, are a little bit misleading. Positive symptoms are things that appear in mental life that don't belong there. Negative symptoms are things that are missing in mental life that do belong there. So, and by mental life, by the way, what we think about is three dimensions: thoughts, feelings, and behaviors. So we have symptoms that that don't belong in mental life that show up, and we're missing things that do belong in mental life. So let's take a look at these two categories. First, looking at positive symptoms. These positive symptoms really come under the rubric of what we call psychosis. When you hear about people being psychotic or having psychosis, they're talking about people who have one of these three different kinds of symptoms: delusions, hallucinations, and extreme disorganization of speech. Let's just take a look at the first two. What is a delusion? A delusion is an idea that has four different characteristics. A delusion is something that is, by its very definition, one of its core features is that it's a false idea. So for example, if I believe that my telephone is tapped and that the CIA is listening in my phone calls. Now, for this to be a delusion, first of all, we have to have some sense of being able to establish that it's false. Another characteristic is that it's fixed. No matter what you try to demonstrate to me in terms of disproving it, I will continue to hold that idea. It is an unshakable belief. I may mutate the idea. I may say, well, you know, you can't find it because they have hidden how they're tapping the phone from you. Or I may say, you obviously are part of it. The CIA has co-opted you, and you are now, part of trying to convince me that I'm wrong. So there are various ways that I will resist that. So it's a false and fixed idea. It's also something that is idiosyncratic. What do I mean by idiosyncratic? What I mean is that it is not a shared belief. So this excludes, for example, religious beliefs, shared religious beliefs that part of groupthink, in which I get together with other people and we develop ideas that we have convinced each other of. It's something that's part of our group identity. So it's interesting. There's a lot that's been discussed about trying to parse religious ideas from psychotic delusions. And that's why the feature of idiosyncratic. And then that it occupies space in mental life. Namely, it's a very deep preoccupation. It's something that's dominating my mental life. It's pushing aside a lot of other thoughts. I keep harping again and again on the fact that my phone is tapped. I can't let it go. I can't stop talking about it. I try to weave it into many conversations. So those are the fundamental features of what a delusional thought is. And it comes in many different flavors. Some flavors are paranoid, such as the example I gave you, thinking that my phone is tapped and that people are trying to do me harm. Some flavors are grandiose. I believe that, I am one of the most important people in the world, and I need to be an advisor to the president, and I have special knowledge, and that many people are, perhaps they're tapping my phone because they understand that I have some special powers. Some delusions, especially sometimes associated with depression, you can have psychotic depression in which the nature of the delusions are depressive. I believe that I've lost all of my money. I'm bankrupt. I am diseased. I am riddled with cancer. I am falling apart. My body is loosening at the joints. Some delusions are bizarre, things that simply couldn't be true. So it's certainly within the realm of possibility that I could have my phones tapped by the CIA. But a bizarre delusion would be, this is actually a true delusion, that not a true delusion, a delusion from a real patient who once I treated in the hospital, who told me that she believed that there were little men in scuba suits swimming around inside of her bloodstream, affecting her organs. Interestingly, she seemed, if any of you have seen the movie Fantastic Voyage, she seemed to have gotten that idea from the movie. That would be an example of a bizarre delusion. And again, I want to emphasize this idea of idiosyncratic. So, the idea that there may have once been a man who died on the cross and was resurrected 3 days later, that is not an idiosyncratic idea. That's shared by millions and millions of people. Now, another feature of psychosis in this domain of positive symptoms are hallucinations. And hallucinations are abnormal sensory perceptions without any stimuli, and they come in all forms. Think about all the different five senses: auditory, visual, olfactory, which is smell, somatosensory, which is touch, and gustatory, which is taste. The most common form of hallucinations that one sees in most psychiatric illnesses, and particularly the family of schizophrenias, are auditory hallucinations. To a lesser extent, visual, and even less so. As a matter of fact, as you go down the list, these other kinds of hallucinations are so increasingly rare that when you see them, you actually start to think about other possibilities. When you see somebody with smell hallucinations or taste hallucinations, if I see a person with that, I actually think brain tumor before I think mental illness, because they're actually rare modalities of hallucinations in mental illness. Now, a very important thing that's often assorted with the positive symptoms is this very interesting word. And to tell you the truth, this phenomenon makes treating this population especially challenging. The word is anosognosia. And as you can see, this means an inability or refusal to recognize a deficit or disorder that's clinically relevant. The word anos means you don't know, and agnosia means you can't perceive. So I've sometimes translated this Greek word as these people, they don't know that they don't know. People don't think that they're ill. You would say, okay, if I heard the clock on the wall talking to me, you might think, boy, that's really unusual. That can't be right. There must be something, maybe there's something wrong with me. Maybe it's a lot like if you started to hear ringing in your ears. You'd say, that doesn't belong there. I need to go see a doctor because there's something wrong with my hearing. I'm having a sound in my ear that doesn't belong there. But in fact, people with schizophrenia will experience something like hearing the clock on the wall talking to them, or hearing a dog talking to them. And or hearing voices where they can't see anybody. And they do not, at least 80% of the time, they suffer from anosognosia. They do not think that it's something inside of them. And they will not be open to the idea that there's something wrong with your brain, something wrong with your mind. You may have a disease. Maybe we should check in with a psychiatrist to see what's going on. They will say, no, you don't understand. The dog really is talking to me. I really am hearing voices coming out of that clock. You can't hear it, but I can hear it. And then they begin to spin a delusional story to explain why that strange thing is happening. Well, the sounds are coming out of my clock because the FBI is tapped into my clock and I'm able to overhear their conversations at headquarters. And you would say, but look, that can't possibly be true. They say, look, it's happening to me. I believe it's true. And I do not accept that this is a mental illness. So lack of insight into understanding that they're ill. And it's one of the reasons why it's often very difficult to convince people to get a psychiatric evaluation when they have these illnesses. Why indeed I ended up having to write a book. You don't need much of a book to convince people to see the orthopedic when their knee is hurting, or the dentist when their tooth is hurting. But in fact, a book to help try to convince people to see a psychiatrist when they're having symptoms like this, it turns out to be something that was very needed, and why I ended up writing such a book based on my own experiences, because people resist getting treatment because of this very common feature of mental illnesses, particularly schizophrenia. 80% of folks have this anosognosia. Now, the negative symptoms of schizophrenia are the other area. And these are things that do belong, that we all should have, that people with these illnesses are missing. And unfortunately, these kinds of symptoms tend to be the more disabling symptoms. So keeping after oneself, attending to one's hygiene. Very often people with schizophrenia are have very poor hygiene. They don't bathe, they don't change their sheets, and they aren't bothered by that. Very often the living area is a mess, full of garbage, full of used food, things which the rest of us would cause an aversive response. We'd wrinkle our nose, we'd feel uncomfortable, we'd want to clean up. The signals that we get that give most people who are healthy discomfort about those things are not transmitted to the mind, are not experienced by people with schizophrenia. There's also a great impairment in motivation, the urge to get up and do things, to be ambitious. There are impairments in memory. They tend to often be very socially withdrawn, and are very overwhelmed in social situations. So they tend to be very isolative. We can show that once schizophrenia begins, people lose quite a few IQ points. It causes an intellectual impairment. And often because of the disorganization in the speech in which people jump from one topic to another or make sentences which aren't very coherent and don't make a lot of sense. They have trouble communicating. These are actually, in many ways, some of the more disabling symptoms, because some of the positive symptoms like hallucinations and delusions, some people are able to keep to themselves and be quiet about and not share with others. And you may not know that someone's having a hallucination unless it's very, very severe and they're talking out loud to themselves, to unseen voices. But many of my patients keep delusions and hallucinations under their hat, but it's these negative or deficit symptoms that are afflicting them in ways that make it very difficult for them to relate both at home and in the workplace. And it's why this is one of the most disabling of the psychiatric syndromes. All right, so those are some of the ways that, some of the symptoms, the ways that schizophrenia presents. Let's look at a few other features of this disease. So first of all, how common is it? So it affects a little under 1% of people nationwide, worldwide and nationwide. And that number is consistent across many, many different countries. That really seems to be an interesting thing. You know, the incidence of cancer, heart disease, and so forth varies from country to country, but the incidence of schizophrenia seems to be pretty constant from country to country. Now, when you think about, however, how prevalent schizophrenia is compared to other illnesses that we worry about and talk a lot about, at least certainly in the pre-COVID days, when this one disease of coronavirus wasn't dominating the entire medical landscape. So you can see here that schizophrenia is about twice as common in the United States as Alzheimer's disease. It's 5 times more common than multiple sclerosis. It's 6 times more common than diabetes, and 60 times more common than muscular dystrophy. And it's interesting, I show you this not just to think about sort of how much more common schizophrenia is than the sorts of things that perhaps many of you have worried about in yourself or in relatives, but also think about the amount of advertising, money, research, and systems that are dedicated to all of these other diseases. You know, you have the telethon, the muscular dystrophy telethon, that's been going on for decades now, all the way back to Jerry Lewis, raising money for muscular dystrophy. We do not have a schizophrenia telethon, even though schizophrenia is 60 times more common than muscular dystrophy. And I will tell you that in terms of its the severity of psychosocial disability, schizophrenia is profoundly more disabling than muscular dystrophy. And of course, it's certainly more stigmatized. And I think that the stigma of mental illness and insanity in general is certainly one of the reasons why, despite these relative statistics, you do not see the level of attention and resources for this disease that you see for the others. Looks like somebody else may be trying to get in here. Give me a moment to. No, they went away. Somebody was trying to get in. Okay. All right, now let's look at kind of the typical course of this illness. The interesting thing is this is an illness that seems to begin in late adolescence and early 20s. You can see that between ages approximately 15 and 25 is the peak onset of this illness. Peaks a little bit later in females than males, but it is sufficiently rare in the 50s and 60s and 70s that if you see people who seem to have what appears to be symptoms of schizophrenia in those older age groups, you do not think of schizophrenia as one of the first things. You think of other possibilities, brain tumors, autoimmune diseases, other things that can resemble schizophrenia. So this is something that comes on right in a very vulnerable developmental period. Think about, you know, what's going on between ages of 15 and 25. That's just the time when people are emerging from their school years. They're making their first intimate relationships. They're going off to college. They are entering the workforce for the first time. So you can see another reason why this illness is so disabling is that it's coming at an incredibly sensitive developmental time. Now, usually, if you kind of think about normal development, you think about one's ability to function as increasing over the course as you grow older, getting better and better, and it's supposed to continue onward well into adulthood. However, between these ages, 16 to 24, what happens with people who have schizophrenia is they begin to fall off the curve. Their functional ability begins to decline by virtue of both the positive and the negative symptoms. Then you may get some remissions where it improves, and then some exacerbations where it gets worse. And you can see as you go further along in the course of this illness, with each subsequent exacerbation of this illness that tends to have some waxing and waning. Each time, this is untreated condition, it gets worse and worse over time. What we call this sort of point of departure from the curve, we call it a life break. And this is something that we recognize when you take a history of people with schizophrenia, is they were doing fine in school and with friends, so forth, and then suddenly they're not doing so fine. And the B student goes to a C student and a D student, and the social young person begins to withdraw and doesn't interact with people, and the emotionally expressive teenager begins to become flattened and unexpressive, and gets worse and worse, and never returns back to the trajectory that they were on before. This phenomenon of a life break is something that's very characteristic of schizophrenia. I'm going to skip that slide, it's too busy. I want to just move forward with thinking about what we know about the causes of schizophrenia. And this is quite a conundrum because frankly, ladies and gentlemen, we really do not have a clear idea of the causes of schizophrenia. It appears to be multiple issues involving genetics, involving environmental experiences, involving sometimes things that people do to themselves, like using alcohol and drugs. This really is the quintessential 21st century disease, a complex combination of factors that are drawn from both nature and nurture, both from biology and inheritance and life experience. We know that there are certain things that correlate with an increased probability of developing schizophrenia. So for example, during pregnancy, there are certain nutritional factors that seem to be more likely associated with schizophrenia, such as lack of choline in the diet. Women who get pregnant with certain viral illnesses, like rubella, during pregnancy, are more likely to have children that become later on, meaning 15 years later, develop schizophrenia. Premature labor is associated with schizophrenia, birth trauma, but so is early life alcohol and drugs, use of cannabis, LSD, cocaine, are all associated with a higher probability of developing schizophrenia during those years of onset. Other things that are being looked at now have to do with parasitic infections, the so-called microbiome of the assortment of bacteria in your GI tract that create chronic inflammation markers. All of this is currently under research. And also people who've experienced more stress in youth are more likely to develop schizophrenia. A divorce, a house fire, sexual abuse, all of that is correlated with the higher incidence of schizophrenia. Of course, not everybody who has those things goes on to develop schizophrenia. As a matter of fact, most don't. But if you look at people who do go on to develop schizophrenia, they are more likely to have had significant childhood stressors or any one of these things. I want to focus a little bit down on genetics because that brings us to the book, Hidden River Valley, because that was a fascinating example. So we know that genetics absolutely play a role, but they don't play the whole role. As I've pointed out, some of these other epigenetic factors, which literally mean things that happen after you have after you're born and you live your life. Genetics is what you're born with. An interesting fact is that if you have an identical twin, you share genes with that twin. 100% of your genes are identical. However, if your identical twin has schizophrenia, your chance of having schizophrenia is only 50%. So if it's obviously not all genes, that's a pretty high chance, 50-50, if you have an identical twin who has schizophrenia, but it's not 100%, it's only 50%. As a matter of fact, this shows you sort of in terms of the degree of consanguinity, Random people in the population have a 1% chance of having schizophrenia. If you're an identical twin has schizophrenia, then you have about a 50% chance, 48% chance. If you have a fraternal twin, and in a fraternal twin, remember you only share half the genes, there your chance of both twin, if one twin has schizophrenia, the other has a 17% chance. And you can see if you have a child then who has schizophrenia, the parent's chance of having it is 13%. If you have a sibling who has it, your percent is 9%. If you have a parent who has schizophrenia, you have a 6% chance. Now, mind you, let's say you have a parent who has schizophrenia, a 6% chance is the good news is you have a 94% chance of not developing schizophrenia. But the bad news is you're 6 times more likely than if you had no family history. Back at the very top, if you were just a part of the general population with no family history. But you can see here how as you have an increased genetic load, you're more and more likely, if you're related to somebody with schizophrenia, you're more and more likely to have developed it yourself. So genetics is important, but it's not the whole answer. Now, we're now capable of mapping the genome, and we've studied a variety of families. And we've been able to identify a number of different genetic markers that have abnormalities in these different families that have a high number of people who have schizophrenia. In the 1st chromosome, in the 6th chromosome, in the 13th chromosome. But the Galvin family seemed to be unique. Prior to the Galvin family, we haven't really been able to identify any genetic markers on the 11th chromosome, and their family turned up on number 11. But the point is that it's not a single thing. If you were going to look for the gene for sickle cell anemia is one gene on one chromosome. And at the moment, I have a mental block against which chromosome that is, but it's only one of them. In schizophrenia, as we've studied families that have a large number of, what you really want is you want a family that has many cases and many non-cases, because you need to be able to compare the genes of the cases to the case, people who have the schizophrenia to people who don't have the schizophrenia. But you can see that different families are sorting in different places. So we say that this is a polygenetic phenomenon. Hold on, somebody else is trying to get in here. Let me admit them and go back. It's a polygenetic phenomenon, and that is there's not one gene, and therefore the biology of schizophrenia is likely to be complicated, and is likely to be many different kinds of, we know there are many different kinds of schizophrenia that have maybe different courses. Some people have grandiose delusions, some have paranoid delusions. Remember the different kind of delusions I told you about. Some people have multiple relapses. Some people only have 1 or 2 relapses. Some people have a more deteriorating course. Others actually have spontaneous remissions, and sometimes those remissions last a lifetime. So that's why it's a family of illnesses, and it may well be because different people have different underlying neurobiologies on the basis of which chromosomes are affected, because there are many different ones in this polygenetic phenomenon. Now, we do know that we can look at some pictures of the functioning brain. This is an example of a PET scan, positron emission tomography. And you can see that the brains of people with schizophrenia certainly look different. These scans record the metabolic activity of the brain. So in this particular case, the more red and yellow regions of the brain have more metabolic activity. They're burning more calories, so to speak. The green and purple are burning fewer calories. And you can see especially, we're looking at the top of these 2 pictures where the number 1 and 2 is, that's the front of the head. We're kind of have a slice, and we're looking down from the top of the head, and the nose is at the top of the picture, and the back of the head is at the bottom of the picture. And you can see that people with schizophrenia tend to have decreased activity in the frontal lobes of their brain. So you can absolutely see that there's different brain functioning. We really do understand now, between the genetics and some of these imaging studies, that schizophrenia certainly is a brain disease that has to do with the abnormal activity of the brain. And older ideas that occurred back in Freudian days, that somehow schizophrenia was a result of how you were raised by your mother, and how there were certain conflicts in the family that would lead to blockages and paradoxes and create craziness as a result. Those ideas have really been overthrown. We really do understand this is a brain disease with roots in both nature and nurture. And we have now identified a number of neurochemicals in the brain, so-called neurotransmitters, that are relevant to this illness, that underlie some of the characteristic symptoms. Neurotransmitters are the chemicals that one nerve cell uses to signal the next nerve cell in a circuit of nerves. And you can see some of the names there: dopamine, serotonin. You've probably heard of some of these: glutamate, gamma-aminobutyric acid, acetylcholine. And you can see that some of these symptoms are linked to these neurotransmitters. And in fact, this is the basis for medication treatment of schizophrenia, because medications that affect these different neurotransmitters affect different symptoms in schizophrenia. The most classic is the dopamine system. And you see here on the right, there are two medicines, actually, haloperidol and aripiprazole, and the aripiprazole is shown at 2 different doses, but they're shown versus placebo in terms of their effect on a score of positive and negative symptoms. This is the PANSS scale, P-A-N-N-S, positive and negative symptoms of schizophrenia. And the higher up the scale, the worse it is. And you can see that if you give these 2 medications, both of which block dopamine in the brain, you can see a very rapid improvement in the symptom scale for both of those 2 medications, the lower 3 curves, compared to placebo. You get an initial placebo response of a few points improvement, and then that response starts to fade, and the symptoms begin to drift up again. So we can get very robust effects from medication, and medication now for the treatment of schizophrenia really is the foundational treatment. It's not the only thing, but it really is to treat schizophrenia without using these antipsychotic medications like haloperidol, otherwise known as Haldol, or aripiprazole, otherwise known as Abilify. Treating it without these medications would be like taking somebody with rip-roaring pneumonia and not putting them on an antibiotic. It's turning the clock back. It's going back in a time machine to, the early 20th century, when the state of the art has such a effective intervention that's possible. So it'd be like telling to treat schizophrenia without medication would be like telling somebody with a fever of 104 and severe pneumonia, just get into a hot shower and put some mustard poultices on your chest, and you'll be fine. Now, there are plenty of other treatments for schizophrenia. There are many psychotherapies that have been designed to enhance the value of medication. There are many rehabilitation programs that help people reintegrate into the community socially, by developing their social skills, vocationally, by providing supported employment to them. The residential treatment programs are often a very, very excellent way of helping people move forward in their development since people get schizophrenia right at that time of life when they're being launched from their families, that late adolescence, early 20s, just as people are beginning to develop the escape velocity and moving out of their families and moving to college and going into places of their own and developing relationships with people other than their parents, a lot of those developmental trajectories are arrested. And residential treatment programs allow people to have sort of an ersatz family atmosphere, but not with mama and papa, with peers, with counselors, with other kinds of rehabilitation specialists that allow people to kind of get extracted from their families, where very often many of these folks are developmentally stuck. It's not unusual for me to pick up a case of somebody who has had schizophrenia and lived with their family their entire life. Their family has sheltered them. They've had a mild enough case that they've really not had to go to the hospital, or it wasn't an emergency to see a doctor, and the families have cared for them. And then the parents die, or they become elderly and move into a nursing home. And suddenly this, 55-year-old person with schizophrenia is on their own for the very first time in their lives. Those are very tough cases to try to begin with only at that stage of life. And another modality that's really emerged in the last 15 or 20 years that's really been quite excellent is our peer support programs. There are actually a number of people now who have this illness who have become trained as peer support specialists. Some of them work in hospitals and connect with the patients that are being treated there. Some of them are available in outpatient settings and in support organizations like the National Alliance for Mental Illness runs a whole peer support program where people with this illness can get together and help one another. And so that's been a very important part of training, of treatment. I want to just note that unfortunately, even though we have all of these state-of-the-art treatments, from medications to all of these other therapies, only about 60% of people with schizophrenia are getting treatment. There are many, many reasons for that. I'm not going to go into them all, but interestingly, the third chapter of my book is "Why Don't People Show Up for Psychiatric Treatment?" It's the longest chapter in the book. There's so much to say about that. But we are only treating about 60% of people, and 40% remain untreated. So finally, I just want to close with a couple of other interesting facts. As I said to you, schizophrenia is one of the most disabling conditions in the world, one of the top 15 causes of disability worldwide. Another thing is that suicide is actually very common in schizophrenia, particularly untreated schizophrenia. As a matter of fact, the suicide rate in untreated schizophrenia is even higher than untreated clinical depression. It's actually a deadlier disease in that regard. And speaking of, ultimately about 5% of people with schizophrenia end up dying by suicide. Remember, there's 40% who are never treated, and the suicide tends to be more likely in that group than in the treated group, although we lose some people in treatment as well. And also, people with schizophrenia, they don't take good care of themselves, as I indicated to you when we talked about negative deficit symptoms before. So as a result, they have more medical illnesses. They smoke a lot more. They have more diabetes. They don't exercise. Their self-care is much poorer. As a result, their lifespan is almost a third shorter than people without schizophrenia, particularly shorter in those that are untreated. And there is an association with schizophrenia and violence. About 13% of people with schizophrenia have had at least one legal run-in for a violent offense. Now, remember, violence does not necessarily mean mass shootings. Violence can mean pushing or shoving or slapping. So, in fact, the majority of violence with schizophrenia are those kind of low-level violences. Of course, you hear in the news sometimes about people who are profoundly mentally ill who engage in mass violence, but it turns out that's actually not the common presentation. But if you include all forms of violence, it's 7 times more likely than the general population. So I just want to close by saying that there are a number of other conditions in psychiatry that we recognize that resemble schizophrenia, but they're different. These are just some examples of 5 other conditions that have a lot of overlap with schizophrenia. And it's, our job to sort out when people come in, say, with psychosis, what are we seeing? Is this schizophrenia? Is this bipolar disorder? Is this delusional disorder? Is this a brief psychotic reaction? Is this a drug-induced psychotic state? It's really no different than any other physicians. When you go into the doctor with a cough, the doctor asks you a whole bunch of questions, takes a history, does an examination, and sorts out, well, could this be pneumonia? Is this bronchitis? Is this allergies? Is this postnasal drip? Is this a smoker's cough? Is this lung cancer? All of these other syndromes that share in common a cough. Part of a physician's goal is to sort out the company that it keeps in order to identify what the syndrome is. And same thing with psychotic symptoms, and there are many other possibilities besides schizophrenia. All right, so that's what I wanted to share with you about this illness. And I'm very glad to take any questions. If when you do ask a question, what I think, rather than unmuting everybody, because that creates a cacophony, I just invite each of you to unmute yourselves when you would like to ask me a question.
I'll ask a question.
Okay, yes, thanks. Hi. Judy, hi.
Hi. I know you talked about schizophrenia as being like the most disabling mental illness, and I'm curious, how does that compare to somebody with borderline personality disorder?
That's a very good question. So borderline personality disorder, so the personality disorders are interesting. They really are, whereas schizophrenia is part of the psychiatric illnesses that are about states. You are in a state of psychosis. Your psychosis is beginning. It has a middle. It can remit. Maybe it's got some chronicity to it. Personality disorders are more about traits than states. We all have personalities, and some of us have traits that are, if you think about traits as a sliding scale, that some of those traits are pushed way out into the periphery at the edges of the sliding scale, and we have to live in a society that's largely designed and made up from people more in the middle of the bell curve with their sliders more in the middle. So there are many different flavors of personality disorders, among the most disabling of which happens to be, this is why you brought it up, borderline disorder. But interestingly, where borderline disorder, the disability that borderline disorder tends to cause is really in one specific domain of functioning. It's interesting that it was Freud who famously said that his definition of mental health was the ability to love and work effectively. So he identified those 2 domains, love and work. Love being relationships, and work being vocational activities, which of course may involve some relationships. So whereas schizophrenia seems to affect both of those areas, love and work, borderline disorder tends to be much more disabling in the world of love than it does in the world of work. In fact, we famously see people with severe borderline disorder who very often are quite high functioning vocationally. Very often, sometimes they're even the heads of businesses and organizations and especially depending if you can get up really high, some of the interpersonal problems that you may have may be overlooked at the top levels. People who aren't going to challenge you or are going to look the other way when you misbehave interpersonally. So the problems that folks with borderline disorder have is more in sustaining relationships, being able to pursue and succeed in intimate relationships. They tend to alienate people, and they often have, as a result of the perceived rejections and slights and feeling alienated, they have a lot of misery in themselves, and a lot of times their own behaviors to cope with that misery tend to actually heighten the misery and can be quite dysfunctional. These are people who often will injure themselves, cut themselves, have a lot of substance abuse problems and so forth. And obviously at a certain point, those things can begin to interfere with vocational functioning. So I'm not saying that borderline people with that construct don't have vocational disability, because sometimes they do, but vocational disability tends to be less and also tends to come on much later. And unlike people with schizophrenia, these folks are often able to get their education, enter the job market, and actually make relationships, although it's hard to hold them. Sometimes they make relationships easily because they're very expressive, they're very emotional, they're very colorful, they're kind of interesting people. Sometimes they actually draw people to them because they're so interesting and colorful. So they have often succeeded at some of those developmental passages that folks with schizophrenia are having trouble with just at the onset of their illness.
Thank you very much.
That makes sense?
Perfect.
All right. I don't know if there are any questions specifically that come from what people read in the book that I might be able to answer. Just also to let you know that schizophrenia is much more likely to result in hospitalizations than most other conditions. Because it is more commonly associated with suicidal thinking. Suicidal thinking or suicidal attempts are often a cause for hospitalization. But also people with schizophrenia sometimes behave in ways that come to public attention and get people brought to the emergency room. Public nudity, public masturbation, public disruptive behaviors that get the police called. And as a matter of fact, police are much more likely to be called to deal with somebody who is misbehaving with schizophrenia than almost any other illness, with the exception of police being called for suicidal thinking, because suicidal thinking covers such a wide variety of psychiatric conditions, not just depression, not just schizophrenia. It's such a common symptom, and one in which inpatient treatment is really especially designed to try and address. So I am.
Dr. Komrad?
Yes, hello.
Hi.
Is this Pat?
It is, yeah.
Hello, Pat.
My daughter started seeing a psychologist when she was 6 years old in first grade, and things progressed from there on. She has been diagnosed as bipolar, schizoaffective, borderline personality. Lately, her sister sees some multiple personalities in there. When I was pregnant for her in my second trimester, I got the flu, and she was a forceps delivered baby. Could you comment on what your thoughts are with those two things and mental illness?
Which two things?
Having the flu during pregnancy and
The pregnancy.
forceps delivery.
Yeah. So, well, before I do that, let me also comment about this drifting diagnosis. So we see that sometimes because remember that, as I said to you at first, and I'm going to use a big word here, psychiatry is a phenomenological science. What that means is we have the phenomenon before us, the symptoms, the hallucinations, the delusions, the emotional lability, the behavioral issues. We're phenomenological science, we don't have another domain of validation. Remember the heart attack example, right? So we can't, even though there's actually a couple of unscrupulous practitioners who will take a lot of your money and try to convince you they can, we cannot diagnose these things with another domain of validation. We can't do a blood test. We can't do an imaging study and say, aha, your daughter does not have schizophrenia. She has borderline personality disorder. Because see this lab test, see this imaging study, see this brain scan. You can see the brain scan. You don't have schizophrenia. You have bipolar disorder. No. The diagnosis is still made from taking a really good history, the longitudinal perspective, and the really good examination, the cross-sectional perspective, asking questions on a mental status exam and observing your patient, and sometimes observing your patient over multiple visits, and being able to put it all together. So sometimes as your observations deepen, the diagnosis begins to change. Also, as new things emerge. So for example, at first, somebody may only have symptoms of depression, but in the fourth or fifth episode, they may begin to start developing symptoms of hypomania or mania, full-blown mania, right? So at first you may say, oh, they have a recurrent clinical depression. But by the fourth or fifth round, they're starting to show the earliest signs of mania, then the diagnosis changes to bipolar disorder, okay? So these are some of the reasons that diagnoses continue to drift. I will also say that you mentioned your daughter began seeing psychologists. I hope that there are psychiatrists in there as well. And that when it comes to diagnostic formulations really are primarily, the difference between a psychiatrist and a psychologist, for those of you who don't know, a psychiatrist is a physician. We've gone to medical school. We've done 4 years of undergraduate, 4 years of medical school, 4 years of residency, just like you do a surgery residency or an OBGYN residency, you do a psychiatry residency. And we are exposed to patients with a wide variety, the entire spectrum of mental disorders, not just people who are having trouble in their marriage or trouble at work, but people with severe mental illnesses all the way through people with more mild things. And we work in hospital settings, and we work in nursing homes, and we work in emergency rooms. We're trained in all of those places. So I think that the most comprehensive diagnostic assessment really is something that that is in the purview of psychiatrists of all the different mental health professionals, as opposed to psychologists and social workers and counselors and so forth. So to answer the question, what is this? What is going on here? What is it and what is it not? And remember, since we went to medical school, we can also think about, is it a thyroid problem? Is it a brain tumor? Is it an autoimmune problem? So we have all of those possibilities in our deck, in our playing deck. Because you mentioned seeing a psychologist. So I just wanted to make a point that I think that that assessment needs to start with a psychiatrist. Now, further treatments can be in the hands of many different mental health professionals. But just like, you would not want your, if you were thinking about whether you had cancer, right? You would probably not start with a physician's assistant, or you would not start with a nurse. You'd start with an oncologist, a physician oncologist. Now, to your more specific question, which is birth trauma. So as I said, that most pregnancies where there's been a viral illness do not end up in mental illness. Most pregnancies where there's been a forceps delivery do not end up in neurological problems or psychiatric problems. So if you start with all people who've had those things and you say what percentage of them go on to mental illnesses, it's a small percentage. But if you do it the other way, what percentage of people that have serious mental illnesses have had a forceps delivery, or had fetal distress in delivery, or had a mother who had a viral illness during pregnancy? A much larger percent of those people you'd say yes to answer that question than you would the people who don't have a mental illness. So it's a statistics thing. And that I know is very unsatisfying, because you can't say a cause and effect relationship. It's a statistical association, just like, we can say, for example, taking more contemporary example, COVID-19, right? More people who are, the people who ended up hospitalized for COVID, more of them had a body mass index in the range of obesity or higher than the general population, okay? But most people who have an obese body mass index who get COVID don't end up in the hospital. So if you take the people who end up in the hospital, statistically, they're more likely to be overweight. But if you take people who are overweight, okay, the vast majority of them are not going to end up in the hospital. So that's what a statistical association is. And you have to be, so it increases, it's a risk factor. That's why we say it's a risk factor, as opposed to a bona fide, predictable cause.
Okay.
So that's what we could say about these kinds of perinatal, we'll call them perinatal phenomenon, what happens during pregnancy and during delivery.
Okay, thank you. And I do want you to know that, yes, she has seen many psychiatrists over the years. I mean, she's 45 and has fired several of them.
Oh, yes. Well, I've been fired by a few myself. Right. The fact is, I find in this field of psychiatry, there's something to be said for optimizing the match. It's a little bit like a marriage. I mean, the relationships are intense. You see your primary care doc, once or twice a year? You see your endocrinologist if you have diabetes, 6 or 7 times a year. But, with my patients, I see them, several times a month, right? And often for an hour at a time. It's not a 7-minute visit. So the chemistry between doctor and patient is very relevant. And sometimes it works and sometimes it doesn't. And sometimes, there are a few people who have to try a couple of different marriages or more to be able to find the optimal match. How often have you heard, people who are incredibly happily married and their first spouse can't believe it? How could anybody be married to that person? I couldn't be married to them. And yet, the next marriage or the third marriage works out fine. So there's some of that as well. Secondly, the issue that we've talked about before, anosognosia, makes it very difficult. A lot of people feel like they don't need to be there in the first place. Why are you doing this to me? Why do I even need to be here? I don't need you. So that leads to a lot of firing. Then, of course, there's the fact that in medical school, we learn a little Latin, because a lot of the stuff is in Latin. And one of the phrases that we learned was illum nullum prandium, which means there's no free lunch. A lot of our treatments have significant side effects. Now, serious illnesses call for serious treatments, but a lot of our treatments have been difficult to take. Now, they've gotten somewhat easier over the years with each generation. So, for example, it used to be that a lot of our medications caused weight gain, right? now some of the newest medications, in order to get a new medication onto market, because several medications have really done very well at improving that side effect of weight gain. If you want to find a niche in the marketplace, you can't bring a medication to market anymore that causes weight gain, right? Because it won't be able to compete with the first couple that came out that didn't cause weight gain. So that's just one example of how some of our treatments and their side effects have improved over time. But anyhow, so a lot of people, complain that we're causing them problems by virtue of the medications that we're giving. And then, believe me, I can go on and on, but I'm going to say just one more thing in answer to this issue about why people, often are unhappy with their treatment. And that is that we still are struggling in this country with insurance parity, right? So what does parity mean? Parity means that you treat mental disorders the same as you treat other disorders. And when it comes to insurance, that means insuring them at the same level as others. So prior to the Affordable Care Act, otherwise known as Obamacare, there was no insurance parity. That meant that if you went in and saw your doctor for diabetes, that your insurance would pay 80% of the bill. But if you saw a doctor for schizophrenia, a psychiatrist, your insurance would pay 50% of the bill. And your deductible for your diabetes was 1/5 of the deductible for mental illness. And your lifetime coverage for your diabetes was unlimited, but your lifetime coverage for mental illness was limited. And back in the day, before the Affordable Care Act, if you had a pre-existing condition, you couldn't get insurance, or it would cost you a fortune. And remember that many of our illnesses, schizophrenia and major depression and bipolar disorder, all hit you before you enter the workforce. So if you can enter the workforce, then you entered the workforce with a pre-existing condition, right? And so that was excluded. I mean, that's one of the reasons why when it comes to mental health, Obamacare was the greatest thing that has ever happened in the history of this country when it comes to mental health. Now, you can argue other reasons why it is or it isn't, but from my domain and my wheelhouse, through my lenses, nothing even comes close to the Affordable Care Act, because Affordable Care Act made parity the law of the land and took away pre-existing conditions. So for my guys, that was an incredible boom. But even still, the amount of reimbursement that you get from insurance is so low that if you're going to take insurance, if you're going to be able to pay your overhead and keep your office open, you're going to have to spend, as a psychiatrist, you're going to have to spend 15 minutes with a patient. Okay? And a lot of people are very unhappy about that. And you can't really address problems, and you can barely talk about side effects, let alone what else is going on in a person's life, right? And it's one of the reasons why, in my particular practice, I feel that I cannot do justice to patients who I sit with for 15 minutes. I have to sit with them for at least 30 minutes or an hour, sometimes 90 minutes. Similarly, when I do an evaluation, when you come to diagnosis, I cannot reach a reliable conclusion in a 30-minute or 45-minute or an hour interview. My initial evaluations are 3 hours. 3 hours, and I go through all the records, and I interview other family members, and I come up with not only really rather reliable conclusions about what's going on here, but what can we do about it. And it takes me 3 hours to do that. Okay. Now, having heard what I just said, it will come as no surprise to you that I do not take insurance. Okay. So because I only see 30 patients a week. Okay. Sometimes between 25 and 30 patients a week. Okay. And I I really only have time to do a new evaluation, 3 hours, a couple of times a month. Because I just don't have, 3 hours available to do that more than a couple of times a month. Okay. If I took insurance, I would be doing 15 new evaluations a month, and I'd be seeing 100 patients a month. So that kind of practice is often very unsatisfying for the patient as well as the doctor. And patients understandably feel misunderstood or feel like the doctor doesn't know them. They feel unknown and misunderstood. They're unable to develop the kind of therapeutic alliance that develops trust. It just, you're doing psychiatry on a shoestring when you're doing that. And so that's another big reason why people don't sustain relationships often and end up, going from person to person. But, it's America, and you get what you pay for. And that is one of the great deficits of the mental health system. There's just not enough money into it. And of all the different specialties, every specialty in medicine, if you look at the amount of insurance money that has gone into it over the course of the last 20 years, it's all been more and more and more, with the exception of psychiatry, where if you look at the insurance dollars that have been spent on mental health, it's been less and less and less over the course of the last 20 years. We are the stepchildren by virtue of the stigma and by virtue of what priorities society has about taking care of the mentally ill. I have a patient that I tried to get into one of these residential treatment programs that I told you about. And their insurance would not pay for such a thing, didn't cover it. Patient was going in and out of the hospital, in and out of the hospital. They would cover that. The cost of 1 year of residential treatment was going to be $150,000. Okay. Insurance, however, did pay for this patient to have a liver transplant.
Oh, jeez.
$500,000. Zero copay. $500,000 for a liver transplant, zero copay. Residential treatment for their schizophrenia, 100% copay. No coverage whatsoever. That's just one anecdote to illustrate what I'm talking about. And a lot of times, sometimes I've been able to argue insurance companies into the fact that they'll save money if they pay for something that's not in the contract, as opposed to something that is in the contract. I've been able a few times to negotiate on behalf of my patients, which is something I can do when I have a full hour to sit with them. And I've been able to flex the benefits, convincing them that it's penny wise but pound foolish to not pay for these things. But most of the time I can't. And so I work at the level of the political level with the American Psychiatric Association and other organizations, National Alliance on Mental Illness, to try and deal with policymakers and legislators and other organizations to try and rectify this cruel, really inhuman imbalance for how our society funds this most human and most disabling of all the illnesses that afflict human beings. Judy, did you want
I
to?
have a related question, although I've already asked one, so if somebody else wants to ask, go ahead.
I have a quick question.
Yes, Kish.
Spent a lot of time fighting and doing prior authorizations with insurance companies.
Indeed.
And I was just wondering, are you having better luck getting the long-acting injectables covered?
Yes, yes. That is it. The long-acting injectables. So just let me say a word about that. So some of these medications can be taken one pill at a time. Most of them are taken one pill at a time. But we do have, for several of them, an injectable form that not only helps acutely, but a single injection can last many weeks, 2 to 4 weeks. And that's nice because since many folks, because of anosognosia, they don't think there's anything wrong with them. It's hard to keep them taking their medication. And so every day is a decision. Should I take the pill? I'm not going to take the pill. I am going to take the pill. But if you can get them on one of these long-acting injectables that you give, they only have to show up once or twice a month to get the injection. And then they're good for the whole month. And it doesn't become a daily struggle with their family sometimes or their programs as to whether or not they're going to take the medication. And because these medications wear off very slowly, since they're sitting in the muscle and they're leaching into the bloodstream, so they wear off very slowly, you don't get as abrupt relapse when they don't show up for medication, and it gives you more of an opportunity to talk them to coming back to the clinic to getting an injection. And they've really been shown to decrease the rate at which people are rehospitalized. So as a result, insurance companies do tend to look upon them more favorably because it saves them money. But of course, then you have to have the patient willing to take the injection, and you have to have, you have to have syringes and needles and so forth, and not all psychiatrists, are equipped to give injections. Some of the medications involve, you have to give the injections in the buttocks, which means you can't be a solo practitioner and without a nurse to pull down someone's pants, and give them an injection in your office. So you have to be in an office that has somebody else who can be their witness with you when the patient drops their pants to give them an injection. And then you can imagine for some psychiatric patients, that becomes a delicate matter in its own right of doing that if you can't give it in the arm. So the answer to your question is generally it is a little bit easier, but the fact of the matter is that there are so many different medications that are available now that there always is something on the formulary that typically an insurance company will approve. And if it doesn't, you can make certain arguments as to why you need this medication rather than one that's on the list. Kish, what is it that you do?
I'm a hospital pharmacist, and I used to see, I was in a psychiatric hospital for a while. I haven't been in a psychiatric hospital for 5 years, but before, you see the patients, they come in, we get them sustained on the Invega Sustaina, Risperidone Consta, they do really well, and they go outside and they couldn't get their long actings covered, so then they back in the hospital. So I was just curious if it sounds like they are covering them more than they used to. So that's what I was
I'd be interested
about.
to know if there's somebody out there who's been working on getting the coverage, right? The fact of the matter is, in my opinion, okay, I am upset if somebody discharges a patient from the hospital on a medication that's not covered by their plan. I consider it a dereliction of duty of the hospital team to not have established the authorization for that medication prior to discharge, because that dumps it in my lap, and then I may not be able to get it. Frankly, there's some people that aren't even willing to try to get it. And then you get a relapse. So I don't know whether your team in the hospital was making any such efforts to make sure that was all in place before assigning the patient to a medication that they couldn't pay for. All right. I'm just hanging out here with you guys. I've got nothing else to do today. So, I'm open-ended if there are any more questions. Judy, you wanted to ask something provocative, as I recall.
Well, I don't know about that. Just to tie this to the book a little bit more, which I realize you haven't read. When we had our book club discussion about this a couple of weeks ago, one of the things that kept affecting me as I was reading the book is the fact that this family had I guess it was 12 kids, I can't remember, 10 or 12 kids, half a dozen of whom had schizophrenia. And yet they attempted to live their life, or they attempted to present themselves as a somewhat normal family. And I found it, I have a stepdaughter who has had various diagnoses. She's probably borderline, but like Pat said about her daughter, you know, you get various diagnoses through a lifetime. I found it almost preposterous that this family could, well, one, that the mom didn't completely fall apart in the midst of all of this, but two, that this family could even sort of function and to some degree function a little bit normally, despite all this constant chaos that was going on in the family. And when you were talking earlier about the insurance, I mean, especially like in my particular case, my stepdaughter's on Medicaid, and we've just had a lifetime with her of trying to find the right physician and the right therapist and the right medication and the right diagnosis, and then it all gets blown up for some reason. And then we find something right, and then the insurance won't pay. And so there's like this lifetime of family affect around trying to help her manage her life. And so then you add in 12 kids, 6 of whom have what you described as the most disabling mental illness. I can't even fathom how that family even, you know, functioned, was participating in research projects, and how did they ever get any kind of decent medical care? It just blew my mind, and it compromised the book for me a little bit. So I'm just curious about what you think about that part of it.
Well, first of all, as a psychiatrist of 35 years, it's remarkable how many families function in the midst of chaos and trauma. I'm having come from a relatively normal family. Of course, normal to somebody you don't know very well. But that being said, it's often an amazement to me what people have been able to survive through in the complexities of families. Secondly, I don't know the book, but I do know that oftentimes people who are involved in studies actually are getting good care as part of those studies. Sometimes one of the best things you can do is to be part of a study. You get a lot more monitoring. You get a lot more of a team that's involved. You get a lot more follow-up that's involved. And that's true, you know, in every branch of medicine when you're involved in a study. So I don't know how that applies to the Galvins, but that may be part of the story there.
Yeah, that's a good point. Thank you.
Yeah. And then finally, I think the toll that these illnesses takes on families, you know, is quite considerable. And it's one of the reasons why I have been very involved with throughout the country with this wonderful organization called the National Alliance on Mental Illness, NAMI.
Yeah.
I don't know if you've had any, and Judy, have you had any contact with NAMI? Have any of you had contact with NAMI?
Yes.
And, you know, NAMI is fundamentally, I mean, I talked about it earlier as running peer support groups, but actually its primary function is family support groups. And as a matter of fact, they teach a course, a wonderful course, and they actually use my book in the course called the Family to Family course. And it's a course where people who have lived experiences, family members who've lived experience are trained in giving the curriculum. So it's not given by a psychiatrist or a mental health person, but by a lived experience family members or set of family members. And it's like a 12-week course. And then frequently what happens is the people who take the course morph into a support group. And so a tremendous amount of wisdom in those rooms with regard to strategies, resources, coping mechanisms that families give one another and support one another and call up one another during crises and so forth to form a community. And of course, you know, social media now has made the accessibility of that kind of support even more robust. And now all the NAMI groups, of course, are online. It makes it even easier to attend. You don't have to find where it is and drive there at 7 o'clock on the other side of town anymore. Just like telehealth, I think, has increased access to many things in many ways. But I think that you know, that kind of family support is important. But the other thing that I will tell you is I think that shame. Shame has a very interesting impact. I think that shame is both simultaneously damaging and fortifying. And I think that people who live in shame, it's kind of like, you know, the frog that's being slowly boiled, right? It creates adaptations. And you know, trying to think of what the version of necessity being the mother of invention would be in this case. You know, hardship, you know, is the mother of coping mechanisms. That people who are living with this kind of stigma and this kind of shame about what's happened in the families, we see this all the time in alcoholic families, for example, that they create very adaptive, novel, and sometimes quite effective coping mechanisms by virtue of the challenges of that hardship. And it's, as a result, I've seen these kinds of these various stories of family dysfunctions lead to quite resilient products of that family. You know, that the children who grow up in families like that really oftentimes have a level of resilience that amazes me. You know, just learning to live chronically. Also, there's a study of people who grow up in war zones, literally war zones, you know, Syria, Lebanon, so forth, that show a sort of higher level of resilience that comes from those societies that, as opposed to kids that grow up in, you know, comfortable places and low stress places. So it's a paradox. It's a paradox. On the one hand, you know, you don't wish anybody hardship and challenge and stress and shame and stigma. But on the other hand, it has its fortifying qualities. So that may be also part of the Galvin family story. Does that seem like it might make sense?
Yeah, thank you. I hadn't thought of the whole notion that with them being so involved in the research projects that they probably were getting better care throughout many years of their life just as a result of that. That's really helpful. Thank you.
Yes. Anybody else? If I exhausted you all? You know, I spend my whole day listening. This is my opportunity to do a lot of talking. So I appreciate the invitation to stretch my wings this weekend.
I have a question.
Yes. Colleen.
Yes, Colleen. It was about the book. It seemed like the book talked about the members of the family who were diagnosed with schizophrenia as having had trouble with either not being on medications long enough. So, not being on the medications and then having bad effects from that. And then it seemed like there was also negative effects from being on the medication for too long. So it seemed like they were damned if they did or damned if they didn't. And I just didn't know if you could speak to that, the difference between, you know, the effects from being on a medication for too long, and then the effects from just going so long without medication. If that makes sense. Does that make sense?
Yeah, well, I would say that the effects of being on medication too long, these are lifelong illnesses. And as a result, they really need, as far as we've been able to tell through research, lifetime medication. It's kind of like having juvenile onset diabetes, right? People with juvenile onset diabetes will need to be on insulin the rest of their lives, right? People with crippling childhood onset rheumatoid arthritis is going to need to be on medication the rest of their lives. People with lupus, these are chronic diseases. You know, they're not acute illnesses like the flu. You know, you get it, it's bad, it goes away, and you're done, right? And maybe you'll get it again, maybe you won't. These illnesses have exacerbations, they have remissions. Some of those remissions are relative remissions where some of the stuff gets better, but not everything. Sometimes, particularly with bipolar disorder, you can have complete remissions, unlike schizophrenia where you can have relative remissions. So people are going to need medications the rest of their lives. Now, long-term effects of being on medication, you know, we know that there are issues, but those issues can be managed. They can be managed. And the question is, are they being properly managed, right? So the metabolic side effects of being on antipsychotics long-term, we can manage that. We can, the metabolic effects on blood sugar, on lipids, on weight, on hormone levels. All of those things can be monitored. They can be managed. How can they be managed? They can be managed with making dosage adjustments. They can be managed by giving medications to treat high blood sugar, to treat high cholesterol, you know, some of the side effects. And they can be managed by making dosage adjustments. They can be managed if necessary, like somebody, say, who's on lithium, who develops the occasional problem with the kidneys that can happen with lithium. That needs to be monitored. And if it's beginning to happen, they need to be switched off of lithium onto a different medication that doesn't affect the kidneys. So if somebody is, you know, so that's part of the lifetime management. So chronic diseases are managed and managed in some of these ways. So that's an appropriate state-of-the-art way of managing long-term medication. And if people are developing problems, then the question that one has to ask is, are they being properly managed? Now, in terms of not being on medications enough or long enough, I think that that's another important part of the discussion, as you point out, Colleen. Most psychiatric medications to treat things like psychosis, like depression, like mania, like anxiety. Most psychiatric medications do not work on a pill-by-pill basis. It's not like taking an aspirin or a Tylenol or an antacid, where you take it and within 30 minutes, you're having results and this symptom is treated, and maybe it comes back, maybe it doesn't, and then you take it again, and then the medicine works again. There are very few medications in psychiatry that work that way. There are a couple. Benzodiazepines like the Valium, Xanax, Ativan family is one example. Medicines for attention deficit disorder, the stimulants, are another example. They work right away, first pill. But other things, particularly treating the illness that we're talking about today, schizophrenia, they take weeks and months to reach their maximum benefit. They don't even start working right away. Antidepressants take 4 to 6 weeks to even start working for most people. Some people are lucky, they get an onset earlier. Antipsychotic medications, for acute psychosis, they can begin working within several days, but then their effect builds over the course of 4 to 6 months. So to get the maximum value, you have to be able to invest the time to do that. But because the adherence rates for some of these illnesses, because of anosognosia, are very poor, it's very often when I see a patient and I evaluate a patient who's had a past history, the question that I ask is not just what medications have they been on, but were they an adequate trial, adequate in duration and adequate in dose. And very often when people say, oh, I've tried, you know, Zyprexa, oh, I tried Seroquel, it didn't work for me. Well, it turns out they took it for 5 days or 2 weeks at only the introductory dose. So I'm not prepared to put that medication in the column of doesn't work, don't try that one again. Now, I may put it in the column of don't try that one again. If somebody said I had a terrible side effect with that, I couldn't take it for, too long because I couldn't stand it. Okay, well, that one then we're not going to go back to, although sometimes I might go back to it and try it at a much more tender dose, a much more tolerable dose, because the person who tried it last time put them on a huge dose right off the bat. So, that oftentimes doesn't work out well. So you go back and you try it at a quarter of that dose and you gradually build it up, and lo and behold, they're able to tolerate it. So these are just the kinds of things that come up in the course of sort of a psychiatrist's ordinary day about how we think about these things. So lifetime medication for many illnesses, schizophrenia being one of them, and for most people, and sufficient duration and the management of medication side effects. These are all part of the art as well as the science of psychopharmacology.
Mark, thank you so very much for what you've done for us today. I really personally appreciate it a lot. And thank you all for coming.
Thank you.
Thank you, Rita, for putting it together too.
Thank you very much.
Thank you.
Thank you.
Yes.
I had a lot of fun. As you can see, I like to educate about what these illnesses are, how we're treating them, and who we psychiatrists are. So I always appreciate an opportunity to do that. Thank you so much for inviting me.
Thank you
everybody.
very much. It was very
Thank you.
informative, excellent. And thank you, Rita, for getting this together.
Oh, you're very welcome. My pleasure.
Thank you. And if
Bye-bye.
for anybody who didn't attend, let me know, and I have the recording.
I will let them know. Thank you.
Take care, everybody.
You
Bye.
too.
Bye.
Bye.